Thank you so much. Let me share my screen and bring up my PowerPoint. So thank you again. So we're going to be talking about the menopause transition tonight. And I say menopause transition because a lot of what we're going to be talking about is that menopause is indeed a transition. It's not one point in time. And there was actually a very pertinent article that was published just on May 25th of 2021 in the New York Times entitled, "Women Can Have a Better Menopause, Here's How." And Dr. Osborne sent this over to me. And there are some really wonderful points that I'd sort of like to reiterate through this talk. So the writer, Jen Gunter, writes, "Many young girls who received no information about puberty woke up one morning covered in blood from their first period, terrified they were dying. This was my mother's experience in the 1940s. And for many women, menopause is a mirror of that. An assortment of unexpected symptoms they may be embarrassed to discuss openly. We can do better by embracing the idea of a feminist menopause. Women deserve to experience these changes in their bodies equipped with facts and free of fear, shame, or secrecy. A feminist menopause rejects the patriarchal notion that a woman's worth is tied to her ovarian function, and that the end of her reproductive life is the end of her productive life." So I don't think anybody could have said this better. And what I want to do tonight, the goal of the talk tonight, is to exactly do that. Let's talk about this stuff. Let's embolden women with facts about menopause, and let's think about what can we do at the Women's Mood Disorder Center as a society to better equip women with information and with treatment. So I'm going to start with a case presentation. So this is a made-up individual. This is Lisa M. She's a 50-year-old married woman with a history of depression, hypertension, and high cholesterol. And she stopped getting her menstrual cycle about 4 months ago. And she says she's noticed that in that time, she's gotten more irritable. She feels more sensitive to things that didn't previously bother her, and she's more isolative. She's had a prior depression. She's actually had prior depressive episodes. One was after the death of her mother, who died of breast cancer. She also had postpartum depression after her second pregnancy, as you heard about from our last speaker, Dr. Osborne. And she's also often struggled with severe PMS, maybe premenstrual dysphoric disorder, like we heard about in our first talk with Dr. Hanso. So she's coming to us because she wants to learn how common her experience is, and if there's anything that can help her with her mood in particular. So let's talk about what the menopause transition is. So the mean age of menopause and the definition of menopause is 1 year after a woman's final menstrual cycle, okay? So the average age is 51 in the United States. And a woman, again, is assessed as, quote, postmenopausal or in menopause a year after her final menstrual cycle. But the transition, the time period where the menstrual cycles become increasingly irregular and she's waiting for that year to be officially in menopause, can be up to 10 years, okay? The average duration tends to be 4 to 8 years. So this is this depiction, which let me just say, I think is incredibly offensive, which is one of the reasons I put it up here, which is a visual depiction of sort of what's happening. So first of all, they characterize a woman's reproductive years as her normal productive life, which again reiterates the point that article so beautifully made, which is this idea that a woman, this patriarchal notion that a woman's value is linked to her ovarian function. And also this idea that suddenly when you enter menopause, your productive life ceases to be. So I would like to change this to reproductive, to her reproductive life, right? And so this is premenopause. And what you see here are estrogen levels. And as the estrogen level falls, and we'll talk a lot about that tonight, she enters perimenopause, which again is this period of increasing irregularity in her menstrual cycle and many other symptoms, which we'll talk about. And then only after about a year, when she finally looks back and says, it's been a year since my last period, is she considered to be in menopause or, quote, postmenopausal. Okay. So why does menopause happen? Well, the big thing that's occurring is that there is a fall in hormone levels, right? So the ovarian reserve, the amount of ovaries that a woman has, diminishes over time. And those are key in producing these key hormones, estrogen and progesterone. And what happens as a woman approaches approximately 45, right? The average age is about 50, is that these levels start to fall. And what I'll show you later is that they don't quite fall as linearly as this depicts. And what you see is that as they fall, this is the period when women experience the strongest symptoms related to being perimenopausal. Okay. So here's a myth that I hear all the time. It's easy for women to tell when they're in menopause. Well, not really, because what I just told you is that perimenopause can last for several years, and women can experience many to no symptoms. And it's not only until the woman looks back in retrospect and says, gee, it's been a year since my last menstrual cycle, that she says, okay, now I'm officially in menopause. Until then, she's kind of in this limbo, right? Where she is waiting to see, gee, my menstrual cycles have become increasingly irregular. Will another one come, or is this it? And knowing that, or not knowing that, for many women really makes a difference, both in terms of treatment as well as in terms of one sort of psychological approach to things, right? Not knowing when something's going to end, or not knowing when certain symptoms are going to end, can be very challenging for anybody. So these are some of the symptoms of menopause. I'm going to go over many of them in much more detail. So here's the other thing I hear a lot, a myth that I want to debunk. You can have your hormones tested to tell you if you're in menopause. And the idea behind this is this sort of false notion that actually the decline in estrogen and progesterone looks like this, when in reality, this is what it looks like. So here are the fluctuations that we see across someone when they're having their regular menstrual cycles, right? So you can see estrogen's in green, you can see progesterone is in blue, and they go up and down. And what Dr. Hanso taught us in our first lecture is that the fluctuations for some women in these hormones around their menstrual cycles are what cause, for some women, very severe mood symptoms. And some of those women have symptoms so severe that it's consistent with premenstrual dysphoric disorder. The perimenopausal period is not just sort of this smooth, steady decline of hormones where you can say, your estrogen is 15, which tells me that you are X number of years into the process. No, there's huge amounts of variability in both progesterone and estrogen as it falls, not only over time, but across women. If you compared one woman's drop in estrogen to another woman's drop in estrogen, it wouldn't give you information because there's so much variability. There's also variability across a single day. These levels fluctuate. And so we can't just get a blood draw. We're not at that point at this point to say, okay, I'll get a blood draw and let you know exactly where you are in sort of this trajectory or this road that you're going through. So what are the symptoms of perimenopause? And the ones that are in bold are the ones I'm going to be highlighting and really focusing on tonight. As you can see, there's many, and we could probably do a talk on many of these, and actually a talk should be done on some of these because we don't talk about them enough. But the ones I want to focus on are bolded here. So some of the symptoms include hot flashes, which are also called vasomotor symptoms, heavy and painful menses. So women can actually experience either more frequent or heavier menstrual cycles, or less frequent and less heavy menstrual cycles. They can have debilitating headaches, heart palpitations. That means your heart feels like it's pounding all of a sudden. Breast tenderness, musculoskeletal pain, restless leg, vaginal dryness, changes in libido, sex drive can decrease, insomnia, difficulty staying asleep or falling asleep, chronic fatigue, low mood, which we'll talk a lot about, anxiety, which I actually added to this list which is, I will make the argument later, I think very understudied in the perimenopausal population, irritability, impaired concentration, and memory problems. And for anybody who has ever experienced depression or works in the mental health field, the reason I have these separated by color is that all of these here in blue are actually associated or can be symptoms of a depressive illness. So when a woman or a man or anybody has major depression, right, or clinical depression, they often have some of these symptoms. And so the symptoms of perimenopause all by themselves have overlap. And for an individual who maybe had a history of depression, it can be very hard to figure out, well, am I having a relapse of my usual depression, or are these symptoms different in some way? So what I want to focus on now is, this sort of says mood swings, but I want to focus on the depressive symptoms that women experience in the perimenopausal time. So I think Dr. Hanso, certainly Dr. Osborne, showed this chart during our talks. And what it is looking at is the difference in the rates of depression. This is major depression. So again, this isn't just depressive symptoms. This is actually being diagnosed with a major depressive disorder. In other words, the level and the severity of depressive symptoms have reached the level that a doctor felt they were really causing significant disturbance in an individual's life or functioning. And what you see and what we've shown you is that women have much higher rates of depression across their lifetime, okay? But the periods during which they have the highest rates of depression are periods when they are experiencing hormonal fluctuations and hormonal changes. So here, as puberty starts, right? As a woman goes through puberty, 10 to 14 years old, look, their rates just go into the sky. 20, they go, 2 times the rates of males. And what's happening there is it's puberty, and the whole hormonal axis is establishing itself. Estrogen and progesterone are fluctuating like mad. And this is the onset of depressive symptoms. Dr. Osborne talked last time about the perinatal period, the time during pregnancy, and particularly in the postpartum, where there's a steep drop in hormones and women are at increased risk of experiencing depressive illnesses. And what we're going to talk about today is here, the perimenopausal time period, when women, again, you can see they start to go down and then they blip right back up again, and they're much higher than males. And then, as you can see, once they're actually through menopause, their rates finally go below that of males. And so again, what you'll see as an emphasis here is that what we believe, the reason that reproductive psychiatry exists as a field, is that this has to do with the interplay between hormonal fluctuations and the very key proteins in our brain that cause depression and anxiety. And when they're altered, that's when we start to see these symptoms. Now, outside of depression, what we found is that 45 to 68% of women actually have symptoms of depression. So it doesn't necessarily reach the level of a major depressive disorder, but they're experiencing, varying levels of depressive symptoms during this time period. So 45 to 68%, which let me just say is double this time period over here, premenopausal. They found that those rates were about in the 20s and 30s. So what are the risk factors for perimenopausal depression? If I was going to look at the whole population of women and sort of say, listen, here are the women we want to be particularly concerned about. What are some of the risk factors that we want to think about? Well, there's some demographic risk factors. So women who start menopause, who start the menopause transition, I should say, at a younger age are at higher risk of actually developing perimenopausal depression. African American women are at higher risk. A lower educational status can be associated with higher risks of perimenopausal depressive symptoms. Lower social support, stressful life events, those can be associated with higher rates of perimenopausal depression. Adverse childhood events. So I think Dr. Hanso talked about this with premenstrual dysphoric disorder, where actually having adversity and trauma in particular in one's childhood somehow, we don't quite understand why, rewires the system in a way that might predispose to perimenopausal depression as well as premenstrual dysphoric disorder. And then medical. So having a prior history of clinical depression or anxiety. So if I have a history of major depressive disorder, I'm at increased risk of having an episode of major depression in the perimenopausal time. In the same way that Dr. Osborne talked last week about women who had a history of depression were at increased risk of having a relapse in the postmenopausal time, in the postpartum time. That's the same here in this population. Women with perimenstrual or perinatal symptoms. So again, this speaks to the fact that some women, we believe, have a genetic vulnerability to these hormonal fluctuations. So if I, as a woman, had a history of being sensitive to the hormonal fluctuations around my menstrual cycle or the hormonal fluctuations around pregnancy, I might be at increased risk for perimenopausal depression. Having an elevated BMI, being overweight, smoking, and other chronic medical conditions can be associated with an increased risk. There's some actual symptoms that we see tend to go hand in hand. So some menopause-associated symptoms tend to go hand in hand with perimenopausal depression. One of those are hot flashes. And a lot of people thought, oh, well, that's because the hot flashes cause sleep disturbance. They wake you up at night. And so that increases your risk for perimenopausal depression. And it's not actually that simple, we're finding out. More so, what it reflects is that these women are really experiencing some of this hormonal vulnerability and variability that we believe increases the risk of perimenopausal depression. So this is sort of my attempt at discussing sort of all of the different things that we believe are at play to increase a risk for depression and perimenopause. So why does depression happen, or why do depressive symptoms happen at increased rates for women in the perimenopausal period? Well, we believe it's sort of complicated. There's many different factors that are kind of coming together, and that for some women that causes this vulnerability. So one part is life stressors, right? Women are experiencing these symptoms on top of some very significant life stressors, right? So, you know, women in their 40s at this point and 50s are often at the height of their career. They may have children leaving their home. They might be starting to take on a role of caretaker for their parents. There might be divorce. There might be loss, right? There are some significant life stressors that happen at this point in a woman's life. Genetic vulnerability. So there is data, again, that some women have what we believe a genetic vulnerability to these fluctuations in hormones. And that with these decreasing levels of estrogen come together and actually change the biological environment in the brain and create depressive symptoms in some vulnerable women. So, and one of the key things here that I want you to remember is it's not just a decrease in estrogen, it's a kind of a variability. It's sort of a fluctuating decrease. And what I'll tell you in a little bit, and you'll see, is that estrogen variability, the more that it kind of goes down in a non-linear pattern, those women are at increased risk for depressive symptoms as well as vasomotor symptoms. So what's the interrelationship between estrogen and some of these very key proteins in our brain? Well, we know that there's a tight relationship there. So estrogen is intricately linked to serotonin. Serotonin, as you may know, is the protein in our brain. It's a neurotransmitter that actually is very important when it signals across neurons in helping us maintain mood. And as estrogen varies and decreases, what happens is that serotonin levels are reduced. We also find that norepinephrine is reduced in parts of the brain. It's also increased in other parts of the brain. And so again, as these estrogen levels fall, it causes changes in two proteins that we know are key in sort of maintaining mood health. And when they go down, they can increase the onset of depressive symptoms. So let's talk a little bit about treatment. So the first line treatment for mood symptoms, for having significant, I would say moderate to severe, certainly depressive symptoms and anxiety symptoms in the perimenopausal period, the first line are antidepressants. So antidepressants, as you may know, include things like SSRIs and SNRIs. That stands for selective serotonin reuptake inhibitors, or selective norepinephrine reuptake inhibitors. Those two proteins that I told you about, basically the medicine works to increase those levels. And so that makes sense, right? If we know that this decreasing estrogen levels and the variability might be causing the decrease in these levels, it makes sense that sort of in the same way that we treat depression at other times in a woman's life, adding back some of that serotonin and some of that norepinephrine is helpful. Hormone replacement therapy, which I'm going to tell you a bit more about in just a little bit, has also been studied to see whether or not if we give back, right? If we give back some of this estrogen, does this improve mood? And the results are a little bit variable. There is some evidence that hormone replacement therapy, giving back the estrogen, can can actually help with depressive symptoms in perimenopausal women, in women who have not gone through that transition, but not in postmenopausal women, which again is interesting because what it suggests is that there's something about this time period when the hormones are fluctuating, not when they have sort of finally plateaued. That's a period of opportunity for treatment. And as you'll see in a little bit, it also tells us that actually the risk factors for these women may be a bit different. There's also some data that hormone replacement therapy plus antidepressants show sort of a potential additive benefit. And again, this has been studied in a few cases. More studies are needed in this area. Let's go back to our case presentation and sort of walk through what are some of the other experiences women have. So Lisa M is also telling me that she's frustrated by continued hot flashes, and that despite using a vitamin, which her friend has recommended, they're continuing to wake her up every single night. She's waking up drenched in sweat, and then she feels sudden chills. She has to sometimes go and change her bed and shower. It takes quite a bit of time, which is leading to sleep disruption. And it's causing her to feel tired at work. She feels like she can't concentrate, and it's starting to affect her performance. So now let's talk a little bit about hot flashes and vasomotor symptoms, right? Again, where do they come from? Why do they occur? And what do we know about the treatment thus far? So these are incredibly common. So this is even more common than depression. 85% of perimenopausal women experience vasomotor symptoms or hot flashes. They can be used interchangeably. It is the sensation of extreme heat in the upper body. That generally lasts a few seconds to several minutes, but for some women, it can be up to hours. They can be spontaneous, coming out of nowhere, or there are certain triggers. So some of the triggers for women can include things like smoking, drinking, caffeine, sudden change in ambient temperature, which we have to encounter in our daily lives. They're accompanied, again, generally by flushing, sweating, but also by heart palpitations, anxiety, and chills. So it's a very uncomfortable feeling, and for some women, a very embarrassing feeling. And it can interrupt sleep, as we're seeing in our case, and be associated with anxiety, irritability, depression, and impaired concentration and memory. And again, it used to be thought that, oh, the vasomotor symptoms are causing the depression or causing the sleep disturbance. But what we're actually finding is that the same thing that causes the depression, the same thing that causes some of the concentration impairment and the memory impairment, which I'll talk about, is the same thing that's causing the vasomotor symptoms. So as you'll see, the more estrogen variability a woman has, the more pronounced and the more likely she is to also be having concurrent vasomotor symptoms. The average amount of time that a woman has vasomotor symptoms is 5 years. So it's a significant amount of time period. And a quarter of women have hot flashes 5 years after they've actually said, okay, I'm officially in menopause. It's been a year since my last menstrual cycle. And that's also important because, again, what we're going to see in a minute is that once sort of the variability has stopped, the treatment options are also different. So this is sort of the depiction of again, sort of the constellation of things that are happening. So there are environmental triggers, as I discussed. And what's happening is that the estrogen variability and the decrease over time is affecting, again, serotonin and norepinephrine. But in this case, it's a little different because what's interesting is that it's actually increased norepinephrine in a certain area called the hypothalamus, which regulates our temperature. And it's actually an increase, a decrease in serotonin also in that same area that basically decreases what is called the thermoneutral zone. So the thermoneutral zone you can think of as sort of, all through this space, you're not going to experience hot flashes or shivering. Your body is going to make it so that you're able to regulate your temperature. And what happens when you're having these reductions in serotonin and these increases in norepinephrine in this area is that it narrows. And what happens is that you're much more likely, as temperatures fluctuate, or as your body is just sort of trying to maintain homeostasis or equilibrium, to get bumped out of your thermoneutral zone and experience hot flashes or shivering. So what's the treatment? Hormone replacement therapy is the most effective treatment for vasomotor symptoms. And so a 2004, what's called Cochrane review, which are looking at many different randomized control trials, it's sort of the strongest way of looking at scientific data, show that on average, the use of hormone replacement therapy can reduce the incidence, the frequency of hot flashes as much as 75% compared to placebo. So I want to take a moment to talk about hormone replacement therapy, which actually goes by a new name, which I'll talk about in a moment, because it's very important to really understand what is it and what are the pros and cons. So oftentimes when I say to a woman, listen, you're having very severe vasomotor symptoms, have you thought about hormone replacement therapy, or what it's now called as menopause hormone therapy, which is a movement, again, to put the emphasis on that we are treating changes over a certain time period in life rather than a deficiency, right? Saying somebody's deficient in something. So I'm going to use hormone replacement therapy, but I just want you to know the more common term these days is actually menopause hormone therapy, MHT. So a lot of women will sort of come to me and they'll make a blanket statement, hormone replacement therapy is just not safe. And the truth is it's not that simple. So I want to tell you a little bit about the history of hormone replacement therapy, why it gained favor, and then why it fell out of favor. So hormone replacement therapy, HRT or MHT, is estrogen, often with progesterone, because progesterone can be protective of the endometrium, of the uterine lining for women. So they are products that are a combination of estrogen and progesterone, and they are synthetic versions called estrogen and progestin. And they gained popularity in the 1970s. And by 1975, estrogen was the 5th most prescribed drug in the United States. And there were many trials looking at both its efficacy as well as its safety. And then there was a very large study that came out called the Women's Health Initiative. And it was a study designed to assess the risks and the benefits of hormone replacement therapy in healthy postmenopausal women. So that's key because actually this population was actually a bit older and they were not perimenopausal and many of them did not have robust vasomotor symptoms. Importantly, that study was stopped in 2002 after showing an increased risk of coronary artery disease, right? So things like, which can lead to things like heart attacks, strokes, and invasive breast cancer, right? Because one of the big concerns about estrogen, which is important, is that taking estrogen can increase for certain individuals a risk of clotting. It can increase a risk of strokes for that reason, as well as breast cancer and other estrogen based cancers. So prescriptions at that point fell 80%. And the fear of hormone replacement therapy, I think, has persisted through today. And that has been, despite the fact that there's actually been some studies that have been done since then that have shown that actually those original studies, those original results were there. There are risks, but the risks are really specific, we think, to certain populations of women and certain time periods. So when you look at the cohort that was in the Women's Health Initiative, they made those, they were able to find and sort of say, look, there are these increased risks looking at the overall group that they studied. But when you actually looked at subsets of the women, what they found was that it actually looks a little different. So younger women who were more likely to be perimenopausal actually had a reduction in cardiac events and all-cause mortality. So women who were in their 50 to 59 were actually part of a cohort that actually found more benefit than risk to hormone replacement therapy. Now, women who were 70 to 79 who were in this study did show increased risk to strokes and cardiac events, as well as estrogen sensitive cancers. So this came up with this new idea, which is called the timing hypothesis, which is that the age and the time at which point a woman uses hormone replacement therapy, and of course her medical risk factors, which I'll talk about, that's really what we need to be thinking about when we decide who's appropriate for hormone replacement therapy. So again, it's this idea that actually there are aspects of a woman's biology that changes once she's 10 or more years from menopause that is different from a woman's biology when she's in the perimenopausal period that change one's risk when thinking about whether or not hormone replacement therapy is right for you. So that's why I say it's not that simple. It actually is a much more nuanced discussion. The current recommendation, the North American Menopause Society is sort of the expert on this, currently recommends that for women aged 60 years or younger, or who are within 10 years of menopause onset and have no contraindications, which I will tell you what those are in a moment, the benefit risk ratio is actually favorable for treatment, and in particular, favorable for treatment for bothersome and life-changing vasomotor symptoms. So it's not for everyone, right? Women who have had a family history of estrogen-sensitive malignant illnesses like breast cancer, who have endometrial hypoplasia, meaning that their endometrium is enlarged in response to estrogen, uncontrolled hypertension, and a history of clots. These are women who absolutely should not be on estrogen replacement therapy. So, but what I want to sort of reiterate here is that sometimes the media, right, is a scary story, and that scary story persists when actually the science is a bit more nuanced. So the point here is that hormone replacement therapy isn't for everyone. And so for those women who it's really contraindicated, what helps with vasomotor symptoms? Well, fascinatingly, antidepressants do. Because as I mentioned before, there's this interplay between estrogen and serotonin. And what we found is that you can actually use low dosages of certain antidepressants to help reduce vasomotor symptoms. So, for example, Paxil is FDA approved for the treatment of vasomotor symptoms. And very low dosages, again, show reductions in the frequency of vasomotor symptoms. Gabapentin and clonidine are not antidepressants, but they are two medications that work on the norepinephrine part of the story that I was telling you about before and sort of correct what estrogen did. So again, you can do the estrogen replacement if it's appropriate for you, but there's ways as we learn more and more about the science to get around that and to use other targets to get at the vasomotor symptoms. So Lisa is now telling me that she's concerned about taking pills. So after seeing her mom treated with chemotherapy for breast cancer, so this is not a woman who is eligible for hormone replacement therapy, she recently read an article online which discussed bioidentical hormones. And it purported that this was a natural, safer way to treat the symptoms of menopause, including mood symptoms. And she's interested in using bioidentical hormones to treat her mood in addition to her hot flashes. So I wanted to bring this up in this talk because I get a lot of questions about bioidentical hormones, and I think there's a lot of misinformation. So first of all, what is a bioidentical hormone? So bioidentical hormones are estrogen-containing products that are derived from soy or yams or animal products. So they actually are able to take out estrogen from these sort of natural products. And many of these products, however, still need to be commercially processed. So there's this idea that like, oh, it's natural because it's coming from a yam or an animal product. Actually, the first estrogen therapy came from bovine urine. So again, it's not actually that much different from the beginning of hormone replacement therapy. But there's this idea, right, that if it's coming from a natural product, it's therefore safer. Well, it's not exactly true because ultimately what happens is they derive the product, it's then commercially synthesized to become bioidentical and useful in a woman's body. And then they market it as bioidentical, but the truth is that it's completely unregulated. So this is not an FDA approved medication, which means that we don't really know whether or not they're bioequivalents. And natural doesn't necessarily mean safer if it's unregulated, because too much can actually be problematic, as we have seen, and too little can be ineffective. So the truth of the matter is at this point is that there's very limited data really showing robust efficacy of bioidenticals. There are limited trials that have shown minimal benefit for the mood, and there's no evidence to support utility in vasomotor symptoms at this time. So I think there's more to be done in this area, but a big part of this, and I hear this a lot, is if it's natural, I'm more inclined to take it. But one of the things I'm always cautious about, and I think there are some really good natural supplements that I do use, but the key here is that we need the evidence to back it up. We need this to be regulated for both safety and efficacy before we market it to women. And I think, again, this has to be part of empowering women to be thinking critically about their bodies and not necessarily giving into sort of commercial processes. So again, we kind of come back to my patient and what are her options? So she's not a candidate for hormone treatment therapy. she does have mood symptoms and she has vasomotor symptoms. So one option for her would be antidepressants because it would help to affect both of those. Now, she's also complaining of concentration and memory issues. So what I want to talk about are the cognitive effects we see in menopause and where research is at this time in this. So women commonly experience cognitive effects in the perimenopausal period. And what they often describe is sort of a sense of brain fog. I think we've all heard that same term, but it was another time of life, right? It was around pregnancy, right? Pregnancy and the postpartum, we think of brain fog, and that's associated with progesterone. And hold that thought, I'll be back to that in a moment. So they also have trouble remembering names, they have trouble organizing and planning, and they have poor concentration. Many women experience great anxiety about this, right? One, because it's potentially affecting their functioning. Two, is because there's a sense of, oh my God, is this, something more serious like dementia or Alzheimer's? The good news is that for the majority of women, again, you have to take family history into account, but for the majority of women, these memory experiences that they're having are not indicative of what's called a global cognitive decline. So they're not indicative of Alzheimer's or dementia. Now, what can happen is a woman will start to have some of these symptoms and they tend to get better. They tend to be time limited and get better once the woman is through perimenopause and into menopause. But then there are appropriate age-related decline in memory. So a big part of this is talking about it and measuring it, right? And understanding that some of these experiences are going to be hormonally driven. The good news is they do get better once she's through the perimenopausal transition. But then there are things to adapt to as one has normal age-related changes. So what do we think is happening here? Again, it's this interplay we believe, and this I think needs a lot more research between lower levels of estrogen and the estrogen variability and these other areas, norepinephrine and serotonin in particular, that affect concentration, alertness. And again, we believe that they sort of modulate each other. And there's more work to be done in this area. So what about treatment? So in terms of treatment, estrogen replacement therapy has shown some benefit in improving cognitive status when given to women, again, in the perimenopausal, but not the postmenopausal time period. So again, it goes back to this timing hypothesis where really, and it tells us about the biology, when there's variability, when there's this transition, sort of adding back can be more helpful. There's, again, not great or robust evidence looking at estrogen replacement therapy in postmenopausal women and helping with their cognitive symptoms. So I want to recap for a moment. What have I told you? So what do we know? Estrogen variability and the decline of estrogen affects serotonin and norepinephrine. And those two proteins are key in many of the symptoms that we discussed today. So adding back serotonin through antidepressants actually helps mood and vasomotor symptoms. That was all because of science that we figured that out. Adding back estrogen helps vasomotor symptoms. Again, early on, when we add back estrogen in the postmenopausal period, less so. And there may be some benefit of hormone replacement therapy to cognition in early perimenopause, but nothing robust for postmenopause, and we need more data. So as a researcher and as somebody who sort of looks at women who continue to struggle with these symptoms, we sort of ask ourselves, what's missing? And what you heard about last time was actually a metabolite of progesterone. So what you'll recall me telling you in the very beginning of this talk is that both estrogen and progesterone reduce over this time period. And they don't reduce linearly. They reduce in this sort of, again, variable manner where they go down over time. And Dr. Hanso and Dr. Osborne told you about a very important metabolite, a breakdown product of progesterone called allopregnanolone, okay, which we refer to as Aloe. And as you might remember, Aloe is what we call a neuroactive steroid that's very important in having sort of anti-anxiety effects in the brain. It has been found to be important in mood disorders in general. So low Aloe levels are associated with depression. And we know that it modulates serotonin and glutamate, which is important in both mood and attention. And we know that there are lower and fluctuating levels of aloe in the perimenopause. So just as progesterone is going down and fluctuating, aloe is doing the same thing. And we also know that aloe has played a key role in other reproductive psychiatric illnesses. So Dr. Osborne showed you last time some of her own work where she showed that every single log decrease of allopregnanolone actually increased a woman's risk for postpartum depression. And Dr. Hanso showed you that allopregnanolone is actually what we believe SSRIs act on when we give them to women who have premenstrual dysphoric disorder to help increase allopregnanolone and then improve their symptoms. So why am I harping on this? Well, there's been an overfocus, I believe, or there's been an appropriate focus on estrogen, but there's a whole other part of this cycle that I think that needs additional exploration, and that's allopregnanolone. And what we know is that estrogen actually acts on two enzymes that help to increase allopregnanolone levels. So as estrogen decreases, again, there might be a decrease in allopregnanolone, which has a big impact, as we know from other studies, on mood and anxiety, and potentially on concentration. That has not been studied. So again, it sort of makes one wonder, well, gee, when we're adding back antidepressants to somebody who's having vasomotor symptoms or who's having mood symptoms in the perimenopause, are all of the benefits really mediated through estrogen? Or is it really that we can add back allopregnanolone maybe, right? We've been adding back estrogen and SSRIs, but is there a way that we can actually study to see whether or not pharmacological treatments that mimic aloe might benefit women with perimenopause? Or to study, gee, is this pertinent? Looking at the targets of allopregnanolone in the brain among women who are perimenopausal will give us a lot of information potentially about whether or not this key progesterone metabolite plays a role in perimenopausal symptoms. So I've added here aloe variability because I think this is one area that that needs additional research. We've shown that it plays a role in other reproductive psychiatric illnesses, and very little information has come to light about its role in perimenopause. There have been limited studies looking at progesterone levels and how they correlate with mood symptoms across perimenopause. And again, very limited studies looking at aloe. And as you might remember from Dr. Osborne's talk, Rexxan alone, which is the first ever FDA approved medication for women with postpartum depression, is a synthetic version of allopregnanolone. So it's an add back treatment. And this leaves us wondering, gee, is this a pharmacologic agent that might be useful in the perimenopausal population? Or are other metabolites related to progesterone playing a role? And should we be looking at the biology there among women who have perimenopausal depression or perimenopausal symptoms in general, cognition, vasomotor symptoms? So this is our hope, right? Menopause isn't a death sentence. We must dispel the misogynist notion that a woman's worth is tied to her estrogen and her age. Instead, we should think of menopause as a new phase of life and the last period as just one landmark along the way. When women need help navigating their symptoms and the health implications of menopause, clear, non-sexist information and proven therapy should be available. And this is what I think we at the Women's Mood Disorder Center really work towards, is that when a woman is coming with us and she's making a decision about therapy, it is evidence-based, right? So it comes from science, and that science is rigorous, it's non-biased, and lastly, it's not necessarily driven by industry or commercial industry. So women deserve that. And with that, I just want to thank the amazing team that I work with at the Women's Mood Disorder Center, my mentors, Dr. Osborne, Dr. Payne, Dr. Hanso, and then the staff that we all work with.